Welcome back to the deep dive. Today, we are really hacking our way through the absolute bedrock of medical knowledge.
We really are.
Our mission is just pure high-yield information. We're pulling foundational concepts straight from key sources like Rubin's Pathology.
Yeah, this is the essential deep dive for anyone who needs that focused, high-speed review of how disease actually works.
Right.
We're going right to the core cell injury, inflammation, repair, and then, tying it all to what you see in the major organ systems. The goal is total clarity, using the real scientific language you need.
Okay, so let's unpack that. We're basically moving up the complexity chain. We're starting at the microscopic level with the cell, because that's where every single disease process begins.
It has to.
Our goal here is clarity on those fundamental definitions and, of course, the most practical clinical correlations.
So let's start with cellular stress. When a cell runs into new demands, it has basically two fundamental ways to adapt before it just gives up: hyperplasia and hypertrophy.
And it's so critical to keep them straight. Hyperplasia, that's strictly about increasing the cell number, which is only possible if the cells can actually divide, right?
Right.
They need that proliferative capacity.
Absolutely. It's a proliferative response to an increased demand. A perfect physiological example is what happens with infants born to diabetic mothers.
Okay.
They've been swimming in high glucose in utero, so their pancreas responds by just ramping up the number of insulin-producing beta cells.
This is a beautiful adaptation, but then it creates this huge clinical problem right after birth.
Right.
Those hyperplastic cells just keep pumping out insulin, and the baby becomes severely hypoglycemic.
And on the pathological side, you see the same thing with the abnormal proliferation of keratinocytes in, say, psoriasis.
Okay, so contrast that with hypertrophy.
Hypertrophy is all about increasing the cell size, its functional capacity. We see this in cells that don't really divide, like muscle. A classic example is the contralateral kidney. If one kidney fails because of a vascular occlusion, the other one gets bigger. It undergoes hypertrophy to pick up the slack.
So the body is literally flipping on emergency growth switches just to handle the demand. And the molecular basis for this is fascinating.
It is.
It's basically showing an increased expression of these growth-promoting genes. Things like mylalic, FAS, FALRAS. That cell is just beefing up its internal machinery without actually dividing.
But what happens if that adaptation fails? Then we move to irreversible injury and, cell death. What's the one event that signals a cell has passed the point of no return?
The ultimate executioner, according to our sources, is a massive influx of calcium.
Precisely. Normally you have this huge gradient, way more calcium outside the cell than inside, but when the cell membrane fails, usually from a lack of ATP, that gradient is lost.
And calcium just floods in.
It floods in, activates all these destructive enzymes, and just seals the cell's fate.
And we see that death manifests in a few different ways morphologically. Let's take liquefactive necrosis. The name itself implies dissolution.
It does, because the dead tissue is literally dissolving into this viscous fluid. This happens when the dissolution of the cells outpaces the rate of repair.
Okay, so why there?
Well, it's really common in bacterial abscesses. The very cells we send to fight the infection, the polymorphonuclear leukocytes, they release these incredibly potent hydrolases that they turn solid tissue into sludge.
The cleanup crew is causing the meltdown.
Exactly. In contrast with coagulative necrosis, which you see in solid organs after ischemia, like in a heart attack.
A myocardial infarction.
Right. The cell outline is actually retained for some time. The structure is there, but the cells are dead.
And tying into this, let's quickly talk about calcification. When we say metastatic calcification, what are we specifically talking about?
We're specifically talking about calcium deposition that's linked to increased serum calcium, hypercalcemia.
That makes the clinical picture so much clearer. You see this in patients with, like, a parathyroid adenoma that's driving up PTH levels.
Or, unfortunately, in patients whose breast cancer has metastasized to the bone, you get these osteolytic lesions that release massive amounts of calcium into the blood.
And that calcium has to go somewhere.
And it precipitates in tissues like the lung alveolar septa or the renal tubules.
Okay, now for the tidy death. Apoptosis. Programmed cell death. What makes it so different from the messy explosion of necrosis?
It's so organized, especially at the genetic level. The hallmark feature is the very distinct organized fragmentation of DNA.
The laddering.
Exactly. Specific endonucleases come in and cleave the DNA at these regularly spaced spots, which on a gel gives you that classic laddering pattern. It's a precise dismantling, not an explosion.
And to wrap up cell injury, a critical example from the liver. We know things like carbon tetrachloride and acetaminophen are hepatotoxins. They get metabolized by cytochrome P450. Where is that enzyme?
It's in the smooth endoplasmic reticulum, and here's the toxic synergy.
With alcohol.
With alcohol. Acetaminophen toxicity is often way worse with alcohol consumption because chronic alcohol intake increases P450 activity, so you generate more toxic metabolites faster, leading to lethal injury and that classic central lobular necrosis.
It's a perfect example of how metabolism can dictate toxicity. Now, speaking of massive cellular responses, let's shift to inflammation. What's the master initiator, the plasma protein that kicks off that huge chain reaction?
That would be Hageman factor, or clotting factor 12. This one factor, once it's activated, unleashes 4 key systems all at once.
4.
Fibrinolysis, the kinins, which cause pain and vasoactivity, the alternative complement pathway, and the coagulation system. It's the master switch.
And speaking of complement, that cascade is just vital.
Yeah.
If I'm thinking about phagocytosis, which specific complement fragment is the crucial one because it acts as an opsonin?
That would be C3b. Opsonization just means coating a bacterium, basically painting a target on it for destruction. It dramatically enhances phagocytosis.
And the cascade also generates other things, right?
Yeah. Oh, yeah, you get C5a, which is a powerful chemoattractant, and the membrane attack complex, which literally punches holes in cells.
Now, when that inflammatory response spirals out of control, like in gram-negative sepsis, we get septic shocks. Which cytokine is the main driver of the direct vascular injury in that scenario?
That falls largely on tumor necrosis factor alpha, TNF-alpha. It's a key mediator released in response to bacterial products that drives that systemic inflammation, the fever, the vascular leakage, everything that leads to shock.
Okay, so let's move inside the phagocyte. Successful bacterial killing, the oxygen-dependent kinds, relies on a key enzyme.
NADPH oxidase. This is so critical. A deficiency in this enzyme is what causes chronic granulomatous disease.
Ah, right.
The phagocytes can eat the bacteria, but they can't effectively kill them because they can't make that respiratory burst of superoxide and hydrogen peroxide.
And this cleanup, it can cause collateral damage.
Absolutely. Lysosomal enzymes released by these phagocytes are the main cause of secondary injury to tissues, like the alveolar basement membranes during a bad bacterial pneumonia. It's a fine line between necessary destruction and collateral damage.
And that damage has to be contained.
It does. The proteolytic enzymes are tightly regulated by inhibitors in the plasma, mostly alpha-1 antitrypsin and alpha-2 macroglobulin. If those fail, you get uncontrolled tissue breakdown.
Now let's talk about the vascular leakage, the edema. The vasoactive mediators cause endothelial cells to contract, creating gaps. Where in the circulatory system does this happen?
It typically occurs in the postcapillary venules. They're the smallest vessels that are most susceptible to these immediate contraction effects, making them the primary site for leakage.
Okay, so once the chaos subsides, we get to repair. Let's trace the sequence. What's the very first event in wound healing?
The formation of a fibrin clot. That's the scaffold.
And right after that?
Right after that, these adhesive glycoproteins called fibronectins cross-link with the fibrin and the new collagen, giving you a provisional stabilization in those first few hours.
And the outcome really depends on the injury. A superficial scrape, where the architecture is intact, that heals by regeneration.
Full restoration. But if you have a huge destructive wound, like a kidney infarct, the body defaults to fibrosis.
Scar formation. And what is that mature scar mostly made of?
It's composed predominantly of type I collagen. The initial, more flexible type 3 collagen gets completely phased out and replaced by the much stronger, much less flexible type I.
That structural switch is key. Stronger, but less elastic. And finally, the central nervous system. Scarring there is different.
It's fundamentally different. The CNS equivalent of a scar is gliosis. This is the proliferation of astrocytes and microglia, and this glial scar is a major, major hurdle.
Because it stops regeneration.
It permanently halts effective axonal regeneration after about 2 weeks. It's why CNS injury recovery is so notoriously difficult.
All right, let's bridge over to genetic pathology. 3 high-yield inherited disorders. First, phenylketonuria, PKU.
It's an autosomal recessive disorder, a deficiency of phenylalanine hydroxylase.
Meaning phenylalanine can't be metabolized, so it builds up to these dangerously high levels. And it's the phenylalanine itself, not its metabolites, that causes the neurological damage.
Right, and clinically you see the effects of that. Reduced melanin synthesis, so fair skin, blonde hair, and that classic mousy odor. The key is timely diagnosis and a strict diet.
Next up, Duchenne muscular dystrophy, or DMD, X-linked progressive muscle degeneration. What's the key protein deficiency here?
It's a deficiency of dystrophin, a critical membrane cytoskeletal protein. And while the muscle degeneration is the main feature, the life-threatening complication we have to remember is the heart.
Right, the cardiomyopathy.
It very frequently leads to a progressive and often fatal cardiomyopathy.
And then there's the most common inherited cause of mental retardation, Fragile X syndrome. The mechanism here is a sort of genetic paradox.
It is. It's caused by the expansion of a CGG trinucleotide repeat right next to the FMR1 gene.
And that expansion it silences the gene.
Through promoter methylation, yeah, it shuts it down. The cell can't make the FMR1 protein, and that leads to the syndrome.
Okay, switching gears to neoplasia. Cancer cells get their immortality by turning on an enzyme that's normally off in adult cells.
Telomerase.
Right.
Telomerase maintains the telomere length, which allows for endless replication. It's a defining feature of malignancy. But before that, what's the definition of carcinoma in situ?
That means the growth is localized. It's confined entirely to the epithelium. It hasn't penetrated the basement membrane.
The key structural barrier. Once that's breached, it's invasive.
And etiology. For skin cancers, basal cell, squamous cell, melanoma, there's a direct correlation with one thing.
Total lifetime exposure to sunlight, UV radiation, a direct dose-response relationship.
And for melanoma prognosis, what's the single most important factor?
The depth of dermal invasion. That pathological measurement, how deep it goes, that defines the patient's risk profile more than anything else.
Finally, in this section, amyloidosis. This is a great example of structure dictating function. These are diverse protein deposits, but they all share a common morphology.
They all adopt that beta-pleated sheet configuration, and that's what gives them their distinct affinity for the di-Congo red.
And the birefringence.
And that characteristic red-green birefringence under polarized light. It doesn't matter if the original protein was an immunoglobulin light chain, like in multiple myeloma or something else, the final structure is the same.
Okay, let's run through some high-yield clinical correlations. Quick hits across the organ systems, starting with infections. For infants, what's the major cause of bronchiolitis and pneumonia?
Respiratory syncytial virus, RSV. It is the most frequent and serious culprit.
In the gut, antibiotic-associated diarrhea and pseudomembranous colitis.
Clostridium difficile, C. diff.
Yeah.
A diagnosis that has become incredibly important in hospitals.
A classic STI presentation. Acute, purulent, greenish-yellow urethral discharge in men.
Neisseria gonorrhea. And for a terrifying disease, rabies. The pathognomonic finding is the eosinophilic neuronal inclusions.
Meagri bodies, usually in the brainstem.
Exactly. Moving to the GI tract, peptic ulcer disease, what's it linked to?
Overwhelmingly, underlying Helicobacter pylori infection and the chronic gastritis it causes. Eradicating H. pylori is often curative.
Now, a section that needs careful distinction. Inflammatory bowel disease, ulcerative colitis versus Crohn's. What's the key difference?
It's fundamental. Ulcerative colitis, or UC, is a disease of the mucosa only, just the inner lining, and it always starts in the rectum and moves proximally.
It's superficial. Contrast that with Crohn's disease.
Crohn's is characterized by transmural inflammation. It goes through all the layers of the bowel wall.
And that transmural nature is why it has that patchy distribution and, critically, why it leads to strictures and fistulas.
Okay, hepatic and biliary path. Primary biliary cirrhosis, PBC, autoimmune antimitochondrial antibodies. What do you see on the skin?
Because of the hypercholesterolemia, patients often get skin xanthomas, and they have intense itching curitis from the bile acid buildup.
And we have to mention chronic pancreatitis.
Highly correlated with alcohol abuse, progressive destruction, fibrosis, and calcifications in the pancreas.
Cardiovascular system. The classic congenital heart defect, tetralogy of Fallot. What are the four components?
Pulmonary stenosis, a ventricular septal defect, or VSD, dextroposition of the aorta, and right ventricular hypertrophy.
And that dextroposition of the aorta is so key because it's sitting over the VSD.
Right. It lets deoxygenated blood from the right ventricle bypass the lungs and go straight into systemic circulation, causing cyanosis.
Okay, hemodynamic disorders, a straightforward one. Hypovolemic shock.
Caused by massive fluid loss, severe burns, major hemorrhage.
And tying back to inflammation, the syphilitic aneurysm of the aorta. This is an infection-mediated vascular problem.
It is. It's caused by endarteritis of the vasa viscorum, the tiny vessels that supply the aorta's own wall. That leads to focal necrosis and scarring of the media, which weakens it.
Finally, renal pathology, post-streptococcal glomerulonephritis. Presents about 2 weeks after a throat infection with hematuria, hypertension. What's the evidence for complement involvement?
Immunofluorescence shows that classic immune complex deposition in the glomerulus. It's strong evidence for complement being involved. The good news is the typical outcome is full recovery.
You contrast that with malignant hypertension, a true vascular emergency. This causes rapid progressive vascular injury.
Right, injuring the endothelial cells, leading to fibrinoid necrosis and the smooth muscle proliferation that gives the arterioles a distinctive onion skin appearance.
To close out, endocrine. Primary hyperparathyroidism causes hypercalcemia and hypophosphatemia, the key clinical risk from that high calcium.
A greatly increased risk of urolithiasis, kidney stones.
And for infants, congenital hypothyroidism or cretinism is most commonly caused by
Thyroidogenesis. The thyroid just doesn't develop. The symptoms, sluggishness, umbilical hernia appear early, and you need prompt hormone replacement to prevent irreversible mental retardation.
Wow, that was a comprehensive synthesis. We moved incredibly fast from the most minute cellular mechanisms all the way through major organ system disease.
And that's the value of this kind of deep dive. It's about cementing those connections. You now have the language to link a microscopic event-like type I collagen formation in a scar or complement activation to the macroscopic clinical outcome, like a mature scar or septic shock.
Okay, so to really cement this knowledge for you, let's turn this into a quick thought experiment. Consider the differences in inflammatory bowel disease we just talked about. Imagine a 25-year-old patient. She presents with chronic, blood-tinged diarrhea and massive colon distension. Her disease is limited primarily to the colonic mucosa. Now, contrast that with a 24-year-old man. He presents with an acute intestinal obstruction, small bowel strictures, and a fistula that extends into an adjacent bowel loop.
So based on the pathology we synthesized today, you should be able to name the most likely diagnosis for each of them, and, more importantly, explain that fundamental pathological distinction, mucosa-limited versus transmural and fistulizing. Use that to deepen your understanding.
What stands out to you? We'll catch you on the next deep dive.